Hello and welcome to the Anesthesia and Perioperative Medicine channel. Merci de nous avoir rejoints aujourd'hui sur la chaîne Anesthésie et Médecine Perioperatoire. Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria.
Welcome, everyone. This deep dive is really for us, for the practicing anesthesiologists. We are, without a doubt, masters of keeping things stable in the operating room. But our role is expanding in some really exciting and important ways. Today, we're going to talk about a critical extension of our skills, palliative medicine. Now, let's be super clear right from the start. This isn't just about end-of-life care, not at all. It's really about leveraging our unique expertise to improve a patient's quality of life at every single stage of a serious illness.
All right, let's kick things off with a number that honestly should make every single one of us pause for a second. 9%. What in the world could that represent in our field? Well, as we're about to see, it points to a pretty significant blind spot in our day-to-day practice. So, that 9%, it comes from a brand new study from 2024 that used high-fidelity simulations of preoperative interviews with a palliative care patient. And what they found was that only a tiny fraction of us, just 9%, proactively, on our own, brought up the patient's advance directive. Look, this isn't about pointing fingers, it's an indicator. It shows us there's a real gap between our incredible technical skills and our readiness to navigate the complex, often messy, psychosocial and ethical needs of our palliative patients. And that's exactly the gap we're here to talk about today.
So, here's how we're going to tackle this. This is our roadmap for today. First, we'll dig a little deeper into that palliative gap I just mentioned. Then we'll get everyone on the same page with the fundamentals of palliative and hospice care, the real definitions. From there, we'll zoom in on our special role as symptom experts, and then we'll tackle what might be the most important skill of all, complex communication. After that, we'll see how to apply all of this in our own backyards, the OR and the ICU, and finally, we'll tie it all together to talk about a new standard of care.
Okay, so let's really get into this challenge. Why is this conversation so incredibly urgent right now? That 9% statistic? Well, it's really just the tip of the iceberg. Let's take a closer look at the data to get a full picture of where we are and, more importantly, where we really need to go. Okay, so check this out. This slide shows a really fascinating contrast that came out of the study. It was a well-designed setup. Anesthesiologist who didn't have special palliative training interviewed a standardized patient. This patient presented with 4 clear problems. And as you can see, we are absolutely brilliant at spotting the concrete medical issues. Things like port access, nausea, pain management. Over 90% of us nailed those. But, and this is the important part, the study showed we often stopped right there. We rarely went on to offer specific, concrete recommendations for therapy. And the most personal issue, the one that touches on a patient's deepest values, their do not resuscitate order, that was the one that was most frequently missed entirely. In this bar chart, wow, it just paints such a clear picture of this communication gap. Let's just walk through these numbers. You've got that tiny 9% who brought up the advance directive on their own. Then you have 50%, half of us, who did discuss it, but only because the patient actor was specifically told to bring it up if we didn't. And then there's this staggering number. 41% of interviews ended without ever, not once, addressing the patient's stated end-of-life wishes. It shows we tend to be reactive, not proactive, when it comes to one of the most important conversations we can possibly have with a patient. So, the conclusion here is pretty unavoidable. Our standard pre-op interview just wasn't designed for the unique complexities of palliative care patients. The study suggests bringing in clinicians with palliative expertise. But that got me thinking, what if we become those clinicians? What if we build that expertise ourselves? And to do that, we have to start with the fundamentals. So let's build that framework right now. Okay, time to build our framework. In this section, we're going to get grounded in the core principles and the history of palliative care. And trust me, this is way more than just a buzzword. It's a deep, rich philosophy of care that, as you'll see, fits perfectly within our specialty. The World Health Organization's definition is really our North Star here. I want you to notice the key phrases: improves the quality of life, prevention and relief of suffering, and that it applies to both patients and their families. This isn't just about the person in the bed. It also explicitly calls out physical, psychosocial, and spiritual problems. This idea directly mirrors the concept of total pain, which was introduced by Dame Cicely Saunders, the amazing founder of the modern hospice movement. The goal isn't just to treat a disease, it's to see the whole person and alleviate their total suffering. And the history of this field really shows this incredible evolution. It all started back in the 1960s, focusing on providing compassionate care for the dying. But then, as we moved into the 21st century, something really critical shifted.
The field realized that these principles of relieving suffering, they apply to all patients with a serious illness, no matter what their prognosis is. But honestly, the most important shift is happening right now, with this huge emphasis on early integration. This is not about giving up. It's about providing an extra layer of support right alongside curative treatments, starting from the day of diagnosis. Now, this brings us to something that trips a lot of people up: the difference between palliative care and hospice, especially here in the US. This table makes it super clear. Palliative care, on the left, can happen at any stage of a serious illness, and it can happen at the same time as aggressive, curative treatments. It's often in a hospital or clinic, paid for fee-for-service. Hospice, on the other hand, that's a specific benefit, usually through Medicare, for patients with a prognosis of less than 6 months who've decided to stop life-prolonging treatments. So the logistics are different, but look at that bottom row. Their core philosophy? It's identical.
And that shared philosophy is delivered by a whole team. This is not a solo sport. It takes doctors, nurses, social workers, spiritual advocates, all working in sync. Now, I want you to look very closely at that last bullet point: additional experts. Right there, in black and white, anesthesia pain experts. Our role is not an afterthought. It is a fundamental, vital piece of a complete palliative care team. This is exactly where we fit.
And that brings us to our unique and, frankly, incredibly powerful arsenal of skills. This section is all about our specific, high-impact contributions. We are masters of pharmacology, physiology, and procedures. We're the specialists who get called in when nothing else is working.
I want you to think about this for a second. Up to 1 in 5 patients with cancer experiences pain that is completely refractory to conventional management. I mean, it just doesn't respond to the usual stuff. For these patients, their quality of life is just shattered by suffering that never stops. This is precisely where our specialized skill set goes from being just valuable to being absolutely indispensable. We can offer solutions that are way beyond the standard medication ladder.
And here are 2 of our most powerful tools in action. What you're looking at are ultrasound images for neurolytic blocks. On the left, we see the setup for a celiac plexus block. This is an absolute game changer for patients with that horrible, intractable pain from something like pancreatic cancer. On the right, that's a superior hypogastric plexus block, which can provide incredible relief for people suffering from pelvic cancers. These aren't just pain blocks, you guys. These are procedures that can give a patient back their ability to eat, to move, and to live with some measure of dignity.
And our arsenal just keeps going. We have neuraxial analgesia, those intrathecal or epidural pumps that deliver powerful medicine right to the central nervous system, which means maximum pain relief with minimal systemic side effects. But the real revolution, the thing that's changing how we deliver this care, is point-of-care ultrasound, or POCUS. This technology is literally setting us free from the 4 walls of the OR. This quote just nails it. It captures the whole spirit of the POCUS revolution in palliative care. It's a total paradigm shift. Instead of forcing frail, sick patients to go through these exhausting, painful trips to the hospital for a procedure, we can now bring our expertise and our technology directly to them, whether that's at their bedside, in a hospice facility, or even in their own living room. It is a profound, profound move toward truly patient-centered care. Okay. Now we need to talk about one of the most ethically complex things we might ever be involved in: palliative sedation. This is an intervention of last resort for patients at the very end of life who are experiencing suffering that is both unbearable and completely resistant to treatment. The definition here is so precise and so important. The intention is to create a state of decreased awareness specifically to relieve that intractable suffering. And this is a distinction that we as physicians have to be absolutely crystal clear on. Palliative sedation is not euthanasia. This table lays out that bright ethical line separating the two, and it all comes down to intent. With palliative sedation, our goal is to relieve suffering. The action is to carefully titrate drugs like benzodiazepines to the lowest possible dose that achieves comfort. And when death eventually comes, it's from the underlying disease. Our deep expertise in pharmacology and titration, our ability to find that perfect dose response for each individual patient, that's what makes us so essential in making sure this is done ethically, proportionally, and correctly. But, our value isn't just about what we can do with our hands or our knowledge of drugs. It's about how we talk with our patients and their families. Mastering a difficult conversation is every bit as critical a skill as mastering a difficult nerve block. So let's work on those skills now. We often find ourselves in the position of having to deliver tough news. The SPIKES protocol is an amazing, evidence-based framework for these exact moments.
It's a 6-step guide that walks you through it. It starts with the S, setting, finding a private space. Then P, for perception. You first ask, what's your understanding of what's happening so far? Then I, for invitation, where you ask permission to share more. Only then do you give the knowledge. The most crucial next step is E, for emotions, pausing to acknowledge and respond with empathy. And finally, S, for strategy and summary, where you make a plan together. It turns a really scary task into a manageable, compassionate process.
Here's another incredibly powerful tool, and this one was designed specifically for our pre-op conversations with high-risk patients. The best case/worst case tool helps us turn abstract probabilities into real, concrete stories. So instead of saying, there's a 30% risk of major complications, you frame it as two distinct paths. Path 1, we do the surgery. Best case, you're back on your feet. Worst case, a long ICU stay, maybe ending up in a nursing home. Path 2, we don't do the surgery. Best case, good quality time at home. Worst case, the natural and often predictable progression of the illness. This helps patients and families weigh the options based on their own values, not just our statistics.
All right, let's take all of these principles and bring them home, right into our primary environments, the operating room and the intensive care unit. This is where the rubber really meets the road. Okay, this is a scenario we have all seen and will all see again. A patient has a DNR order and they need an operation. It is absolutely not enough to just see the DNR in the chart and move on. The pre-op interview becomes a critical moment. We have to have an explicit conversation. We need to clarify their goals for the surgery itself, and we must discuss how that DNR status applies to the specific, often reversible, events that can happen under anesthesia. It's all about shared decision-making to create a truly customized perioperative plan, which includes exactly when and how that DNR order will be reinstated. Now, in the ICU, palliative care can be woven in a few different ways. The consultative model is probably the most familiar, right? We call in the specialist team for a consult. But the integrative model, that's where we, as the primary intensivists, take the lead. We're the ones proactively identifying patients who need these conversations, leading the goals of care discussions, and managing complex symptoms ourselves. The trend, and the goal, really, is for all of us as intensivists to develop these primary palliative care skills so we can really live that integrative approach. This diagram is fascinating, and it offers a really powerful lesson from our colleagues in pediatrics. It compares the disease trajectories. For adults, you can see that palliative care often doesn't ramp up until things get very advanced. But now look at the trajectory for children. That focus on family-centered care, on support, it starts right at the moment of diagnosis, and it's sustained all the way through. This model, early, integrated, and intensely family-focused, is exactly what modern adult palliative care is striving to become. It's all about preventing crises, not just managing them when they happen. And that brings us to our conclusion. We've looked at the problem, we've built a solid foundation, we've explored our unique skill set, and we've talked about how to apply it. So now, let's pull all these threads together and define a new standard of care where we, the anesthesiologist, play a central, keystone role. This quote from Current Opinion in Anesthesiology just perfectly sums up our unique position. It's the combination of two things: our interpersonal skills, which we sharpen in every single high-stakes pre-op interview, and our profound expertise in pharmacology. That combination is what makes us such a valuable, irreplaceable dimension of the team. We're the ones who can bridge that gap between technical intervention and compassionate communication. We are not just service providers. We are core members of the palliative care team. So what are the big takeaways for you to bring into your practice? First, extend your paradigm. Palliative care is active, holistic support that can and should begin at diagnosis. Second, please recognize your value. Your expertise in refractory symptom management is a truly irreplaceable asset. Third, make yourself a communication expert. Tools like spikes and the best case/worst case framework should be in your toolbox. And finally, integrate these principles proactively. Don't wait to be asked, make this part of your everyday practice. So we'll end with this question for you to think about. We are already the keystone of perioperative medicine. We're the connection point between surgery, critical care, and pain management. The opportunity in front of us now is to be the keystone that solidifies the bridge between our highly technical world and the world of holistic, compassionate, patient-centered palliative care. Thank you so much for your time and attention today.